Okay, picking up where I left off previously, talking about factors that can affect blood pressure when you're trying to maintain and regulate blood pressure. So keep in mind the previous part or the part above in your notes where we are, the relationship between blood pressure and blood flow. Blood pressure and blood flow are directly proportional, meaning that when you increase blood flow, you will increase blood pressure. When you decrease blood flow, you decrease blood pressure. And then blood flow and resistance are indirectly proportional or inversely proportional. I'm sorry. So when you increase the resistance or something to oppose the flow will decrease. If you decrease the resistance, then blood flow will increase. So consider that on this part here, 4 factors to affect blood pressure. One factor would be resistance, anything that opposes the flow. Ways that resistance you can think about it. Vessel diameter. If you have a smaller diameter, then this will increase resistance. Think of the diameter of something, the tonal situation I gave you earlier. If my tonal is smaller, then it's a possibility that I can bump the walls and bump things on the side to slow down my movement. So if I have less space, I have increased the resistance, and now increasing resistance will increase the blood pressure. Blood viscosity. If you increase the viscosity or the thickness or stickiness of it, you increase the resistance, and this will also increase the blood pressure. When you think about the length of the vessel, if I increase the length that I have to travel, like the systemic circulation, this will increase the resistance, and that will increase blood pressure. So you can see if you increase the resistance, you can increase blood pressure. This is not blood flow, this is blood pressure. So here is a situation from the book where it kind of explains the situation with your baroreceptors and the reflex and the effect it has on the blood pressure. So you can see, start at the top picture, where the stimulus, say you sense that the blood pressure is increased here. Remember that your reservoirs for blood would be your veins. So at any time, most of your blood is in the veins. So you could try to, based on what's going on in the body, you could try to increase the blood flow to the heart and make it bypass lingering in the veins. Or you can, based on what's going on in the body, blood can know to slow down or not get back to the heart so fast and linger in the veins possibly. So depending on that, going from there, thinking about that, you have a stimulus here where blood pressure is increased. So the arterial blood pressure rises above normal range. So the body sense, okay, blood pressure is high right now. Those baroreceptors in your carotid sinuses and aortic arch, they will be stimulated. So once they are stimulated, the impulses will go to the brain, and then that will stimulate your cardioinhibitory center and inhibit your cardioacceleratory center and inhibit your vasomotor center. So now you have a signal going to the heart and you have a signal going to your vessels. So when it goes to send those signals there, it will decrease your sympathetic impulse to the heart, and this will cause your sympathetic system. This will cause a decrease in your heart rate, decrease in contractility, decrease in cardiac output, because remember, blood pressure is high. On your in your vasomotor center, as far as how this will affect your blood pressure, this will decrease the rate and impulses, allowing for vasodilation to take place, and this will cause a decrease in resistance. So because you have a decrease in resistance, I don't want to slow down anything going to the veins, so blood can stay in the veins a little longer, kind of linger there, and not get back to the heart so quick. So this will decrease your cardiac output and decrease resistance and return blood pressure to the homeostatic range, or in other words, bring that blood pressure down. So I'm allowing blood pressure is high at the time. I'm decreasing the resistance. In other words, I don't want anything to stop it from being in the veins at that time. That's the way I think of it to make it easier, since that's the reservoir. So in other words, it can stay in the reservoir a little longer, and that will decrease the blood pressure and not get it back to the heart. So it would be the opposite if you had a, here, the bottom part of the seesaw situation. So say you detect that blood pressure was low. You're going to stimulate the receptors in the aortic arch, and it's going to send a signal to the brain, which will send a signal to stimulate your cardioacceleratory center. So it's saying blood pressure is low, so we need to make sure blood is getting back to the heart at a good rate and not lingering in the blood vessels. So it's going to stimulate your sympathetic system, increase your heart rate, increase cardiac output here. It's going to cause for vasoconstriction to increase resistance in the vessels. So I don't want the blood staying in the blood reservoir too long. I need it to increase the resistance to the reservoir, and that'll make it go back to the heart quicker. So when the pressure is low, you send a signal to increase heart rate and all of that to get your pressure back, to increase resistance, which will get pressure back up. So hopefully that makes sense. Make sure you ask me questions if that is confusing. Factors that can affect blood pressure also, the blood vessel elasticity. If you decrease the elasticity of a vessel, this will lead to increasing the blood pressure. So if you decrease the ability to stretch, it can expand and the pressure will increase to make the walls weaker and weaker. And so when this happens and lead to those weakening of the walls, it will cause an increase in the blood pressure. With blood volume, if you increase blood volume, this will increase fluids on the wall. In other words, putting more pressure on that wall because of the increased amount of fluid there, or the volume has increased. So this will increase the pressure as well. As far as cardiac output, you could consider heart rate and stroke volume, because if you mess with any of those two factors, it will affect the cardiac output. So with that being said, if you increase the cardiac output, you increase the blood pressure. Ways to increase cardiac output is in messing or affecting the stroke volume. So if you decrease stroke volume or decrease the heart rate, this will decrease cardiac output and this will decrease blood pressure. So all of these are factors that can affect the blood pressure, depending on if you're trying to get pressure up or if you're trying to get pressure down. So remember, the vagus nerve is a part of the parasympathetic system. So it decreases heart rate while sympathetic impulses increase heart rate. Sympathetic is your fight or flight system. The vagus nerve is your parasympathetic, a part of the parasympathetic, and that is your rest and digest system. So here's a picture visual giving you an idea of factors that can increase the cardiac output. Exercise, I'm sorry, I went too fast. Exercise, which increase the activity of your pump, respiratory pump, muscular muscles, your sympathetic venoconstriction situation, which is affecting your veins and the rate at which things are returning. This affects your stroke volume and so forth. Same thing with decreasing blood pressure. Activates your cardiac centers in the medulla, and you can see how that can lead to increase in heart rate, and that can lead to increasing your cardiac output. So these are just ways you can look at to kind of get an idea of how to increase the cardiac output. The way that the blood pressure is regulated, you have your short-term system and your long-term system. So your short-term is neural and hormonal control. In other words, your nervous system and your glands releasing hormone. It controls blood pressure by altering your peripheral resistance, by altering the blood vessel diameter and altering blood distribution. This is the one that's active when you're doing changes, and it's monitoring constantly when you're going, changing movements, for instance, or changing positions, like going from reclining to standing, and being able to adjust quick enough so you won't faint or something like that. So this is your short-term system. It's sensing. It's kind of like a little policeman going around monitoring and sensing your different body positions or whatever is going on in the body, whether you're exercising or whatever, and it can adjust accordingly. And it's going to do that by altering your blood vessel diameter and altering the distribution. Diameter, you saw in the previous part, that we just did about how you have smaller diameter, it increase resistance, which can increase blood pressure. And then it'll be vice versa. If you increase the diameter, you have decreased resistance, and then that will decrease the pressure. Blood distribution is based on what's going on in the body. Your body will send blood to that part, whether it's the digestive system, if you just ate, if it's your muscles, if you're exercising at the time, and so forth. So based on all of that, your body will adjust and send blood where it's needed most, instead of sending it to a place where it is not needed. And that goes back to the first part when I was talking about going through the capillary bed, and the sphincters in some areas can be closed because you might not have to have blood flow increase to that area, versus if you're doing some type of other activity and the sphincters through the capillary bed are open because you want blood to get to that area. So your baroreceptors will monitor changes in your arterial pressure and stretch, and your chemoreceptors respond to changes in levels of chemicals like CO2 or carbon dioxide, or hydrogen or O2, in other words, oxygen. So these are chemical receptors. They respond. Baroreceptors will respond to stretch or change in size, in other words, of something. These receptors will send the information to your vasomotor center in the brain, and the higher centers in the cortex and the hypothalamus, which of the brain, may modify your blood pressure controls. So your hypothalamus, you might remember, is a part of your sensory signal that's receiving relay information for your five senses to help adjust and adapt to whatever's going on as a part of your autonomic nervous system. Long-term regulation is by your renal system, or when you see renal, think of kidneys. Your kidneys alters blood volume. Your kidneys will increase urine output to lower pressure. So if your pressure is too high, then your kidneys will begin to work to cause you to have an increased amount of urine going into the nephron, to cause you to have to go to the bathroom to lose fluid to get that pressure down. Your kidney, if you sense that blood pressure is low, then you will decrease, your kidneys will decrease output, and you will have fluid not going into the nephron, but going back into the bloodstream, for instance, and that will help raise the blood pressure. And that will make perfect sense when we get to the kidney chapter. But for now, you do need to know that the kidneys is the part that monitor your long-term regulation of blood pressure. And that's the blood pressure you're checking, your constant blood pressure, which is considered normal, and all of that when you're checking. So it's not your just change in position. It is your overall blood pressure, and it is your kidneys that keep that regulated. Now, you have hormonal mechanisms that will adjust your blood volume, your cardiac output, or your vascular resistance. And remember, if you increase resistance, you increase blood pressure. And the opposite, if you decrease resistance, you decrease blood pressure. So different hormones that you can consider. You can have epinephrine or norepinephrine. The effect on the blood pressure, it will increase blood pressure. What does it change? It will increase your cardiac output and peripheral resistance. And this happens in the heart, and it acts on your arterioles. So that's how you will interpret this chart. Angiotensin, this works to increase blood pressure by changing resistance. And if you increase resistance, you increase blood pressure. Remember that. So this happens, or it acts on your arterioles. So this is the factor right before going into the capillary bed. ADH, or antidiuretic hormone, it is a hormone that is released to increase blood pressure by acting on or by changing peripheral resistance, or just resistance, by increasing resistance, and it can increase blood volume. Think of the term antidiuretic. Diuresis is going to the restroom and urinating. So antidiuresis is against diuresis. And then, so that means that it does not want you to lose fluid, but keep fluid in the body. So if you increase resistance, you increase blood pressure. This hormone is active on your arterioles and the kidneys. Aldosterone works to increase blood pressure. by increasing blood volume, and it's active on the kidneys as well. Aldosterone is probably more specific. It works on your salt levels, and that is because that water will follow salt. So it works on your sodium levels, in other words, and that will indirectly affect your fluid because water is going to follow. Antidiuretic hormone is affecting more or less your water directly, H2O output or input. You have cortisol. It works to increase blood pressure, and it changes your blood volume by increasing it, and it will work to decrease water and salt loss and cause you not to lose those fluids, and it works on the kidneys. Atrial natriuretic peptide, it decreases blood pressure by decreasing the resistance, and it is active on the arterioles. So it will cause vasodilation by decreasing that resistance, and it works on the arterioles. So that's the only one you see I put it in order to try to help give you a flow there. All of them work to increase blood pressure, except AMP, it works to decrease blood pressure. Keep in mind also, if it says volume, if you see volume, you know that it's working on the kidneys, because kidneys are your long-term regulators that work on blood volume. And you know, if it's resistance, it's working on your arterioles or heart, but mainly arterioles, those vessels. And that goes back to that seesaw picture that I showed you earlier. So volume, think of kidneys. Blood volume is working on those kidneys. Make sure you read the chapter on the homeostatic imbalance on hypertension and hypotension, which is high blood pressure, low blood pressure. Read those. Be prepared for a matching section. Simple definitions, nothing in great detail. Now, autoregulation of blood flow. Here, you'll see that blood flow is inversely proportional to the cross-section area of the vessel type. So if you increase the cross-section, this will decrease blood flow. So the more crossing that I have to do, it's going to slow down the blood flow versus if I had a straight shot, in other words. And if you remember the network of the capillary bed, it has a lot of crossing going on there. So blood flow is fastest in the aorta and is slowest in the capillaries. Aorta is more of a straight shot. Capillaries, I have that nice little webbing network going on. So I have a lot of cross-sectional work going. So that slows it down. Perfusion in the tissues is regulated at the capillary beds by those precapillary sphincters that can close and shut based on the need. If it's not needed, then those sphincters will close off, and that will let blood increase its flow to another area where it's needed. This is called autoregulation. So here's a visual, give you an idea of that. So you can see here, velocity of blood is fastest. It's the fastest in the aorta. It slows down as it gets towards those capillary beds. This complements the function. In the capillary bed, it is the place where gas is exchanged. I'm dropping off oxygen, picking up carbon dioxide, and so forth. Well, since that is taking place in that area, you don't want it to take place too fast, or you don't want blood to go through there too fast, because you want to give things time to exchange. So it makes sense for things to slow down as it reaches the capillary bed. After the exchange takes place and it's going through the veins, then the speed can, or it will, pick back up to the vena cava, lead into the vena cava, and going into the right atrium. The total area of the vascular bed, you can see how the area is lower in the aorta, and then it increases as it moves into capillaries and so forth, and then the venules and veins, it goes back down through there. So the increased area that it has, or the more crossing that it has, the slower that it moves through. So autoregulation of blood flow. Factors to open and close sphincters. So we're just going to do open, and you know the opposite of this would be to close the sphincters. So this is what's happening through the capillary bed. If it sense decreased oxygen levels, this will open the sphincters, because that oxygen is coming from the arterioles, And so it say oxygen levels are low. So these sphincters need to open up and allow that oxygen to rush out and get to that tissue. If carbon dioxide levels are increased, this is going to open it because carbon dioxide is considered waste and you want to get that out of the tissues. So it's going to open up the sphincters to get it out. pH levels are low. It's going to open it up because remember, this is in the blood. pH, if it's too low, you don't want it to get too acidic. Blood is alkaline, if you remember from chapter 17. Decreased blood pressure is going to open the sphincters to get blood going through there to increase the pressure. Decreased nutrients, which is being carried with that oxygen and so forth. And then increased body temperature. This will help to get the sphincters open because when they get them open, with that temperature increase, it'll get them open and then heat can leave the body. I believe you also have an extra blank for BV, that's blood volume. If you sense decreased blood volume, so put decreased blood volume, that will cause the sphincters to open up as well. So in order to close the sphincters, it would be the opposite of all of these arrows. Skeletal muscles will increase perfusion tenfold during exercise. So during, you can see here at rest, you have, I'm so sorry. At rest, you can see perfusion to the brain. And what the rate is in milliliters per minute. The heart, skeletal muscles, skin, kidneys, abdomen, other. When you have strenuous exercise going on, it is going to be constant for the brain and heart. Skeletal muscles, you can see how it increased so much from 1,200 to 12,000 because you have all of your muscles active and you want blood getting there at a good rate to accommodate your activity at the time. You increase the flow as well to the skin because you're increasing your temperature. So as that blood flow is going, you have some heat that's needing to escape as well. The abdomen, you have decreased flow there. And you might notice that the flow to different areas will go down because a lot of blood is going to the muscles at the time. Brain perfusion is going to be constant no matter what. You're not going to change that because it's the brain. And you don't want to change the pressure around the brain. Skin perfusion can change from 50 to 2,500 with that increase in your body temperature. Heart perfusion is 250 milliliters per minute at rest. It will increase with exercise. Of course, that makes sense because your heart is working faster and beating and working to pump that blood and get it out at a good rate to accommodate the fact that you're exercising. So this is just showing how the things can change and your body can adjust based on the need at the time of wherever that blood is needed compared to where it's not needed. So capillary exchange of respiratory gases. Most nutrients and gases move in and out of the capillaries by diffusion. It's passive. It's simply going to move from high concentration to low concentration easily. Some large particles can move in penocytotic vesicles. So that's moving in the vesicles and it's pulling in the particle as well as the fluid in the environment around it. Fluids will move due to change in the pressure gradient. Being high pressure in one area is going to be attracted to the low pressure area. And so it's going from, like you learned about diffusion, from high pressure to low pressure. Hydrostatic pressure is the push of water fluid. So it's pushing, it explains how things are pushed out of the capillary bed to the surrounding tissue. Osmotic pressure is the pressure that is needed to pull fluid back from the tissues into the vessel. So we're talking about the exchange of, when we're saying the exchange of gases and so forth, and we dropping it off in the tissues and picking up the waste. This is the pressure that must be overcome in order to push things out and to pull things in back into it to carry it back towards the lungs or the heart, lungs and heart. So some vesicles you'll see when we say the change in gradient, this is your filtration and absorption. You'll learn if you're in your notes there, filtration If you're filtering something, is using the water, just like thinking of a coffee pot, using something that water pull through and filter through something, and the solutes might not go through, but the water will go through. And then absorption is your body keeping something. When something is being secreted, it's leaving your body. If it's being absorbed, it's being kept in the body. You have your hydrostatic pressure in the capillary bed. You also have the hydrostatic pressure in the interstitial fluid. So IF is the interstitial fluid, which is simply the tissues around the vessel. So this promotes filtration or fluids moving out of the capillary bed. Then you have the osmotic pressure in the capillary bed and the osmotic pressure of the interstitial fluid. This will promote absorption or fluid moving back into the capillary bed. So it's moving from the surrounding tissue back into the bed. So your net filtration pressure equals the net pressure of your net hydrostatic pressure subtracted from or minus your net osmotic pressure. So think of the arterial end. We're picturing that right now. That is where filtration is taking place. So your net hydrostatic pressure, your hydrostatic pressure of the capillary is 35 millimeters of mercury. Your hydrostatic pressure of the interstitial fluid is 0. And this is because we assume it's 0 because if anything leaks out into the interstitial fluid, we have our lymphatic situation, our lymphatic system that picks up anything and put it back into our circulatory system. You'll talk about that in chapter 20 and 21. So you assume it's 0. So 35 minus 0 is 35 millimeters of mercury. Your net osmotic pressure, which is your pressure to pull a substance in, is 26 for the your net osmotic pressure for the capillary bed. Your osmotic pressure for the interstitial fluid is 1. We assume that the lymphatic system would pick it up, but you have a few proteins that can affect that pressure. And then 26 minus 1 is 25. You take those two numbers, 35 minus 25, and you get 10 millimeters of mercury. So this pushes fluid out. So the bulk fluid is from the capillaries to the tissue space at 10 milliliters of mercury. I will not ask you to give me the math, for instance, saying 35 minus such and such, unless I gave you an example and you will just be able to do the numbers from reading the problem. The way to interpret this is saying that in order for fluid to leave out of the arterial, out of the capillary bed and go into the tissue space, it has to have a positive pressure of 10 millimeters of mercury. So this is what's going to push that oxygen out of the capillary bed and push it into the surrounding tissue or whatever that tissue might be. So that's the pressure to push out. On the venous end, you got to have a pressure to pull stuff back in. So how do I get things to pull back into the venous end, or for instance, the capillaries, the carbon dioxide and any other waste? I need to pull that into the capillary bed in order to send it to your vena cavas and so forth. So the net hydrostatic pressure in the capillary bed, you have a hydrostatic pressure of 17. The interstitial fluid is 0. Same reasons because of your lymphatic system. So that gives you 17 millimeters of mercury. Osmotic pressure in the capillary bed is 26, and the interstitial fluid is about 1. And that's because of proteins that might get through. 25 is the number here. 17 minus 25 will give you a negative 8 millimeters of mercury. So this negative pressure is what's going to pull water in. So the bulk flow is from the tissue space into the capillaries because of this negative pressure. You have about 85% of filter fluid is reabsorbed. Anything that's filtered out is going to be reabsorbed or pulled back in. And if it is not, it'll be, if not, returned to the bloodstream, by the lymphatic system. So still, if it's in the tissue space, you still have the lymphatic system, that the purpose of it, part of its purpose, is to catch anything that leaks out of the circulatory system, and it put it back in, and it flows in the direction of your veins. So here is a picture from your book showing it. Here's your capillary bed. You have the arterial end, you have the venous end. So you have pressure that's going to, imagine that this is the capillary bed, because capillary bed is microscopic, you cannot see it. So imagine that this is sitting inside of a big kidney. So we have a kidney, and you want some things to be pushed out into the kidney, and some things to come back as waste into the blood, into this capillary bed, to go back into the vena cava, heading out as waste. So this is the pressure that has to be overcome in order to push something out into the interstitial fluid. So that's into the fluid around it in that kidney, for instance, in that organ, whatever organ you want it to be. I just said the kidney. So you have that net pressure of 10 millimeters of mercury that's going to be overcome. So that oxygen that's being carried in here is going to be pushed out of this vessel now and go into that tissue. Then on this end, I have a negative pressure situation going on that's going to pull things from this interstitial fluid into this capillary bed. So things are being pulled and things are being pushed out. And that is a negative pressure system on the venous end, or the ends of the vein, to pull waste and carbon dioxide into this capillary bed. So make sure you let me know if you have questions about that pushing and the pulling in order to exchange those gases. Now get into your circulation pathways. Some of these we discussed, and there'll be a little reviews, and some will be new. You have your systemic circulation. This includes all blood vessels carrying blood from the left ventricle to the body tissues except the lungs and back to the right atrium. So this is your left side of the heart working to pump that blood from the left atrium to the left ventricle to the aorta to your arterioles, arterioles into that capillary bed. And then going to the venules, the veins, the vena cava, back to the right atrium. So in the tissues is where you dropped off that oxygen that was picked up in the lungs. Arteries carry oxygenated blood in the systemic circulation, and veins carry deoxygenated blood in the systemic circulation. You also have the pulmonary circulation. This goes from the right ventricle to that pulmonary trunk, and then from there to the pulmonary arteries to the lungs. So it's going through the lungs, back into the left atrium through those pulmonary veins. In the circulatory, or in the pulmonary circulation, the arteries carry deoxygenated blood. So that pulmonary trunk has deoxygenated blood, D meaning decreased levels of oxygen. And the veins, the pulmonary veins, that is those are the vessels carrying oxygenated blood that has just been picked up in the lungs. So the pulmonary circulation is opposite the systemic circulation. So here's that system going on. You can see the heart here in the middle, and you can see the right atrium, the right ventricle, going from there into your pulmonary trunk to the pulmonary arteries to the lungs, and so forth. And then the left side, you can see how it's pumping and sending signals to the aorta, to the arterioles, and that's leading to your capillary bed. And you're exchanging gases in all of your tissues. And you can see the organs that belong to the that are above the diaphragm, the ones below. Areas below the diaphragm is coming back, picking up waste and sending it to the inferior vena cava, and then the ones from the other is sending it to the upper part of the body, sending it to the superior vena cava, and they're both heading to the right atrium. You see the capillary bed in the I was saying superior vena cava, back towards it. And then you can see here in the gray that is representing your pulmonary circulation, where it's going to the lungs and back into the left atrium. So the arteries in this entire systemic circulation with the red and blue, the arteries carrying oxygenated blood, the veins carrying deoxygenated blood. In the pulmonary circulation, where you can see the gray, the arteries they're carrying deoxygenated blood, and the veins will be carrying oxygenated blood. The other pathway you have is the portal hepatic. When you see the term portal, that means that it goes through two capillary beds. Hepatic meaning, think of the liver. So after a meal, substances from the digestive tract need to be processed by the liver. So when you eat something, your body's going to decide what it can keep and what's needed and what it does not want to keep and what is waste. If it's going to be kept, your body's going to pull it, put it in that, it wants to go into the bloodstream, it's going to be absorbed. If it's not going to be used in that digestive tract, it is heading into the large intestines, it's coming out as feces. So in the small intestines is where the absorption is taking place. After it decides what it's going to pull and be absorbed, it's not going to put it directly into the bloodstream, it's going to send it to the liver. And then when it goes to the liver is like a detoxification center. It's going to process it. And then from there, it'll put it back into circulation. So this circulation, the portal hepatic, it detours venous blood from the GI tract and spleen through the liver before returning it to the heart. Portal meaning it goes through two capillary beds. So it's going through the capillary in the small intestines and then in the liver. And from there, it's going into the circulatory system. Your hepatic portal vein is what carries the blood to the liver. So the hepatic portal vein is what's going to carry. So that blood is oxygen poor, but it is nutrient rich. Remember that it's just been absorbed in the small intestine, so it has a lot of nutrients. It may have some toxins, which is why it's going to the liver to be processed and detoxified, but it is oxygen poor at that time. So here is the hepatic portal circulation. You can see the stomach located. From the stomach, you get substances. Everything's jumping around. Going from the stomach to the small intestines. From the small intestines, things are going to be absorbed. And then if it's been absorbed, you can see the hepatic portal vein here and its connection leading to that liver. So that blood is going to be absorbed and it's going through the hepatic portal vein into the liver for processing. I'm so sorry. It's going to the liver for the processing. And then from there, it'll go back into the system. Another circulatory system is the fetal circulation. At birth, the fetus will have 3 shunts, and they should close after birth. If they do not, then you can have a surgical procedure where they close them off. But normally they should naturally close. One of those shunts, these are shunts to help blood bypass, for instance, the liver and the lungs, especially the lungs because it is not fully developed. It is the last to develop. They're not strong enough to take on the pressure coming through there. So they have these special shunts during development that form to bypass those structures. The ductus arteriosus will connect the pulmonary artery to the aortic arch. And if you remember from pulmonary trunk, pulmonary artery goes to the lung. So you don't want it to go to the lung, so it's going from the lung right to the aortic arch. So this protects blood from circulatory overload, or lungs from circulatory overload, and it gives the right ventricle time to strengthen. Upon closure, the name changes to the ligamentum arteriosum. You might remember that from the heart dissection, that little remnant that's a part of, that's right below or part of the aortic arch. Another shunt they have is the ductus venosus. It's the blood vessel connecting the umbilical vein to the inferior vena cava. This will carry high oxygenated blood. It bypasses the liver and gives it time to develop. And upon closure, it becomes the ligamentum venosum. The third shunt is the foramen ovale. and it shunts highly oxygenated blood from the right atrium directly to the left atrium, not going into that right ventricle. If some gets into the right ventricle, then remember you have the ductus arteriosus that connects the pulmonary artery to the aortic arch. But this one helps it to bypass the right ventricle because you do want the ventricle, give it time to strengthen. And this is the one, because this ventricle is going to the lungs and back and so forth. Upon closure, the foramen ovale become the fossa ovalis. And this was the one you saw in your picture in the heart dissection, maybe. And it was in the right atrium, in that interatrial septum. This picture I Googled, so if you want to find one yourself, you can, and that's fine. Here's the ductus arteriosus going from that pulmonary artery to the arch of the aorta. You can see the foramen ovale going from the right atrium to the left atrium. And then you can see the ductus arteriosus that is traveling here from that right atrium to the left atrium also. And then the ductus venosus from the right atrium to the left atrium, and the ductus, the foramen ovale, from right to left, ductus venosus from the umbilical vein to the inferior vena cava. So those are the shunts that you can see, and all of these help bypass that liver and the lungs. Now, different ways to check the functioning of the heart, and we did some of this in lab. One way is by checking the pulse. This is checking, this pretty much can tell you if the heart at least is contracting and relaxing. So the pulse, you need to use your fingers, not your thumb, and you can press below the wrist at the base of the thumb. You have other places that you can check, of course. You can also check the carotid at the base of the neck or at the neck, not on both sides at the same time, one at a time. Radial pulse is thumb side at either of your wrists. These are just two of the common spots. You have several other locations where you can check pulse. You can use a watch or a clock with a second hand, and you'll count beats per minute for 1 minute. Depending on the status of the person you're checking, if you do it for a full minute or if you do 30 seconds and multiply it by 2. If you know that they're having irregular beats, you will need to do it for that full minute and listen. A good average is about 75 beats per minute, but for the most part, you'll know that normal is 60 to 100. So a good medium between there is about 75 beats per minute. Here's a picture. It is from your book showing the carotid and radial arteries where you can check pulse. I put them in red, but also you can notice that there are other places that are common for checking pulse as well. It's important to check those, like I stated before in lab. If you know you have a blood flow problem with the person, then you want to check those pulses to see if you're getting a pulse through there, because that can tell you if blood is getting through. Another way of checking the status of the heart is by checking blood pressure. The instruments used is called a sphygmomanometer, and you will use a stethoscope. Sphygmomanometer is just, you might say, blood pressure cuff. You will put the cuff on the brachial part of the arm right above the bend of the elbow, stethoscope in your ear, and you'll tighten the valve to the right. After you tighten it, you'll use the bulb on there and you'll pump it to about 180, 200. You can ask the person, do they normally have high blood pressure or normal? If they normally say my blood pressure is 220, then pump into 200. You might not hear anything. So it just depends on the person, but normally about 180, 200 is good. You'll loosen the valve to the left after you pump, not too fast because you'll make the needle on the meter that you're reading go too fast. So you want to open it very slowly to the left. The first sound you hear is your systolic number when taking blood pressure, of course. In other words, that is the top number. And the last sound you hear is your diastolic number, and that goes on the bottom. 110 to 120 is normal. 70, or is a good range. 70 to 80 for your diastolic number is a good number for the bottom. So here's a picture of a blood pressure cuff or a sphygmomanometer, as well as a stethoscope. Homeostatic imbalances to be familiar with. Circulatory shock is failure of the cardiovascular system to deliver adequate blood. Three ways that circulatory shock can take place. It could be hypovolemic shock. Hypo means low, volemic, think of volume. So they can have low blood volume, and this can be because of a large amount of blood loss, like if a person is hemorrhaging or so forth and they're losing a lot of blood. So the volume is going down and they can go into circulatory shock that way. Another way is vascular shock. This results from extreme vasodilation and decreased resistance. So if you decrease the resistance, remember, you're going to decrease blood pressure. So blood pressure can drop pretty low and cause for that circulatory shock in that manner. Another way is cardiogenic shock. So this is affecting the heart. This results when the heart is inefficient and it cannot sustain adequate circulation. And this can lead to circulatory shock, because remember, if the heart isn't working right, then the blood isn't getting sent out at a good rate, because that is the job of the heart, to pump and get that blood out. So that is the end of chapter 19. Also for chapter 19, you are responsible for knowing the blood vessels that goes with those notes. You should have printed those out with chapter 19 notes. I have already taken the liberty of adding what those blood vessels supply and what they drain. When you see the word supply, you know it's an artery. Artery supply an area. In other words, it's sending blood to an area. Veins empty out an area. So blood is leaving that area and emptying into the veins. So when you see a question saying what structure or what vessel supply, you can eliminate a choice that says veins or something vein, because you know I'm talking about an artery. What structure drains an area or does blood empty into? You know I'm talking about a vein versus an artery. Most of your vessels, if you know where they're located, it would make sense as far as what structure it supplies. So make sure you study that. I don't just kill you with questions like that on your test, but there are about 5 to 7 questions about blood vessels, ask you about those vessels. Also, interpreting that, you can see how on your chapter 19 notes, it'll show how something goes from, you'll have the arteries and then they have arrows branching off of that artery. And then that should make sense. And then for veins, it'll have the arrows going in the opposite direction because it's showing the veins empty into that. So when you're studying that flow, let me know if you have any questions.